Okay, let's unpack this. Have you ever wanted to truly master a complex topic, to understand it so deeply that you feel like an elite professional in the field? Today, we're embarking on a deep dive into one of medicine's most intricate and impactful battlegrounds, the world of cytotoxic and antimetabolite drugs in cancer chemotherapy. This isn't just about knowing facts, it's about connecting the dots, understanding the ingenious strategies at play, and truly grasping the nuances that make these therapies both powerful and, well, challenging.
Indeed. What's truly fascinating here is how these compounds, some discovered by sheer chance or, from unexpected origins, exploit the fundamental weaknesses of rapidly dividing cancer cells. Yet in doing so, they also reveal the remarkable complexities of cellular function and repair, pushing our understanding of biology itself.
So our guide for this journey, it's this incredibly rich, really in-depth chapter from a top pharmacology textbook. And our mission, well, it isn't just to skim the surface, right? We're aiming to meticulously uncover the intricate mechanisms, those subtle differences.
Exactly. The historical breakthroughs, the clinical insights, everything that makes these drugs, both potent healers and sometimes formidable challenges.
Yeah, get ready for some serious aha moments as we build a truly comprehensive, professional level understanding of how we wage this chemical war against cancer. All right, let's jump right into our first major class of potent agents, alkylating agents and platinum coordination complexes. We'll kick off with an overview of their common actions and their historical significance. So when we talk about alkylating agents, we're looking at a broad and, frankly, very important category of chemotherapeutic drugs. This includes various subgroups like nitrogen mustards, nitrosoureas, and triazines. What unites them is a shared critical characteristic. They all form these highly reactive intermediates that act kind of like chemical magnets.
That's right. These intermediates are exceptionally reactive. They form covalent links or permanent chemical bonds with sites in cells that have a high electron density. And while they can react with many cellular components, their primary and most impactful target is consistently the N7 atom of guanine, one of the 4 building blocks of DNA.
Right.
This specific interaction is, well, it's believed to be key to their biological effects. But their reach is broad. They can also hit other reactive spots on DNA bases and even amino and sulfhydryl groups in proteins, including glutathione, which, as we'll see, becomes important for detoxification.
And here's where it gets really interesting. We often discuss platinum coordination complexes right alongside alkylating agents, even though they don't technically alkylate DNA in the same chemical sense. Why are they linked in our understanding of how they fight cancer?
Well, what's fascinating is that while platinum complexes don't form the same type of carbonium ion intermediates, they achieve a remarkably similar therapeutic outcome. They form covalent metal adducts with DNA, essentially creating a different kind of permanent blockage or lesion.
Okay, a metal adduct instead of an alkyl group.
Exactly. But this ultimately produces disruptive effects on DNA function and cell survival that are very much like what classical alkylators do. So despite differing initial chemical reactions, there's this convergence in their therapeutic effect, which is why they're often grouped together for study and, importantly, clinical application.
Got it. Now, moving to the historical context. The origin story of these drugs is quite unexpected, almost a paradoxical twist of fate, really. It traces back to observations made during chemical warfare in World War I. Specifically, the widespread toxicity of sulfur mustard gas was noted.
Right, not just the burns.
Not just the topical burns, it severely affected the bone marrow, causing a profound drop in blood cell production aplasia, and led to significant gastrointestinal ulceration.
Indeed. This dark chapter paradoxically provided a crucial observation. It was then in 1942 that Louis Goodman and Alfred Gilman, yes, the originators of the pharmacology textbook, that's our source material here, made a pivotal demonstration.
Amazing connection.
It is. They showed that nitrogen mustards exhibited potent activity against mouse lymphoma. This groundbreaking work then rapidly led to their clinical studies, where they administered intravenous nitrogen mustards to patients with lymphoma. And this marked the true launch of the modern era of cancer chemotherapy, born, incredibly, from a devastating historical event.
So a dark chapter paving the way for a major breakthrough. It really shows how unexpected observations can lead to profound medical advances, turning something destructive into, well, a tool for healing. Now let's dive deeper into the precise mechanism of action on DNA using mechlorethamine, A prototypic nitrogen mustard, as our example. Think of it as a tiny chemical bomb, right? Can you walk us through how this drug actually interacts with DNA at a molecular level?
Certainly. The process begins with an activation reaction within the cell. Mechlorethymine first undergoes an internal chemical rearrangement. It forms an unstable, highly reactive three-membered ring structure called an aziridine ring.
Okay, an aziridine ring.
Yeah, and this ring is the key to its potency. It makes the molecule an electrophile, meaning it's highly attracted to electrons.
So this aziridine ring is the active species, the real troublemaker for the DNA. What happens next?
Once formed, this highly reactive aziridine intermediate is primed for what we call alkylation. It performs a nucleophilic attack, basically. It seeks out and covalently links to electron-rich donors in the cell. And as we mentioned, its primary target is that N7 atom of guanine on the DNA molecule. This covalent bond fundamentally alters the guanine base, essentially jamming a key piece of the cell's blueprint.
And this is where the bifunctional nature of some of these drugs comes into play, right? I understand that drugs like these nitrogen mustards aren't just one-trick ponies. They have a second reactive site. What does that enable them to do that makes them so powerful?
Precisely. This is critical for their extreme cytotoxicity. Bifunctional drugs, unlike their monofunctional counterparts, possess a second reactive side chain. This second side chain can undergo a similar cyclization and reaction.
So it can react twice.
Exactly, allowing it to alkylate another guanine residue, perhaps on the opposite strand of the DNA helix, or even link the DNA strand to a protein. This results in the formation of interstrand crosslinks, where the two DNA chains are covalently locked together, like, tying them in a knot, or DNA protein crosslinks. These alterations cause a major disruption in nucleic acid function, and it's widely believed that the extreme cytotoxicity of these bifunctional alkylators correlates very closely with this interstrand cross-linkage of DNA, because these complex lesions are far more challenging for a cell to repair or even, replicate past.
That sounds like a very effective way to just completely gum up the works. But what's the ultimate result of this DNA damage? How does it actually lead to the cancer cell dying?
Well, while the exact sequence of events leading to cancer cell death following DNA damage isn't fully known, the current understanding points to a crucial difference between cancer cells and normal cells. Cancer cells, often driven by their relentless and uncontrolled growth signals, are already pushed much closer to the apoptosis threshold. That's the point at which they initiate programmed cell death.
They're already living on the edge, so to speak.
Kind of, yeah. So when alkylating agents inflict significant DNA damage, they essentially push these already stressed cancer cells over that threshold, triggering apoptosis. Normal cells, in contrast, generally receive growth and survival cues that keep them well above this apoptosis threshold, making them relatively less susceptible, although certainly not immune. It's really about exploiting an existing vulnerability in the cancer cell.
So it's leveraging that inherent instability. What about DNA repair mechanisms? How do cells try to fight back, and how does that relate to drug susceptibility and resistance? This seems crucial for that professional level understanding.
Absolutely crucial. Cellular responses to DNA damage involve sophisticated DNA repair mechanisms. Think of them as the cell's internal cleanup crew and alarm system. In non-dividing cells, for instance, DNA damage activates a checkpoint, a sort of internal alarm system largely dependent on the presence of a normal p53 gene, often called the guardian of the genome.
Right, p53.
This checkpoint halts the cell cycle, usually at the G1S interface, giving the cell time either to repair the DNA damage or, if the damage is too severe, to undergo apoptosis. It's a critical self-preservation mechanism.
And what happens if that p53 is faulty or missing in a cancer cell, which I know is quite common?
Well, that's a major mechanism of resistance. Malignant cells with mutant or absent p53 often fail to suspend cell cycle progression effectively in response to damage. They don't undergo apoptosis as readily, and this deficiency can lead to significant resistance to alkylating agents. It's like, turning off the alarm system that would normally trigger cell self-destruction, allowing the damaged cells to just keep dividing.
So the damaged cells just keep going.
They do. And beyond p53, the specific repair mechanism depends on the type of DNA damage and the cell's overall repair capacity. This involves various DNA repair enzyme complexes. For example, defects in a pathway called homologous recombination DNA repair, or HRD, can make cells more sensitive to platinum agents. In fact, characterizing HRD status in clinical tumors has now entered clinical practice as a way to select patients who might benefit most from certain therapies. That's a fantastic example of precision medicine in action.
That's fascinating, using the cell's own repair deficiencies against it. This all hinges on the cell's ability to actually recognize the damage first, doesn't it?
Precisely. Recognition of DNA adducts is an essential first step. The Fanconi pathway, which involves about 12 distinct proteins, is a key system here. It recognizes a broad array of DNA damage from drugs, from irradiation, and signals the need for repair. If any component of this pathway is missing or inactive, cells become extremely sensitive to DNA damage.
Okay. And what about other pathways? You mentioned mismatch repair earlier.
Right. For methylating drugs, nitrosoureas, and platinum agents, the mismatch repair MMR pathway is absolutely essential for their cytotoxicity. The MMR pathway recognizes mispaired bases, or small insertions deletions, that can result from adduct formation. It then initiates strand breaks at these sites, and this damage signal ultimately triggers apoptosis. So a functional MMR system is actually needed for these drugs to kill the cell effectively.
It's almost counterintuitive. You need a repair system working for the drug to be fully effective in some cases.
It is, in a way. It highlights the complex interplay between damage repair and cell death signaling.
Now let's talk about mechanisms of resistance to alkylating drugs more broadly. It sounds like cancer cells are pretty quick to find ways around these treatments. It really is like an evolutionary arms race.
Right. They are, unfortunately. Resistance to alkylating agents can develop quite rapidly, especially when a drug is used as a single agent. This constant adaptation by cancer cells highlights a really profound insight. Single-agent therapies often fall short in the long run. It's why modern chemotherapy often relies on strategic combinations, trying to hit multiple vulnerabilities simultaneously, sort of outmaneuvering the cancer's next move. This isn't just about finding potent drugs, it's about understanding the dynamic interplay of survival and resistance. There are several specific biochemical changes that have been implicated in resistance.
Okay, let's break those down. What are some of those key changes that allow cancer cells to outsmart these drugs?
Well, one common mechanism is decreased permeation. Cancer cells can essentially learn to shut their doors or reduce the activity of transporters, making it harder for actively transported drugs like methchlorhethamine and melphalan to even get inside the cell in the first place.
So keep the drug out. What else?
Another strategy involves increased intracellular concentrations of protective molecules, primarily phiols like glutathione. These molecules can effectively bind to and thereby detoxify the reactive intermediates of the alkylating drugs, basically neutralizing them before they can damage the DNA.
Okay, neutralize the threat internally.
Right. Then there's the increased activity of DNA repair pathways. If these pathways become overactive or more efficient, they can rapidly remove the drug-induced DNA adducts, diminishing the drug's cytotoxic effect. The specific repair pathways involved might differ depending on the particular alkylating agent, as we discussed.
So the cancer cells can either keep the drug out, neutralize it inside, or clean up the damage faster. What other tricks do they have?
They can also exhibit increased rates of metabolic degradation of the activated forms of prodrugs, like cyclophosphamide and ifosfamide. Enzymes such as aldehyde dehydrogenase can convert these activated intermediates into inactive metabolites before they even reach their target.
Break it down faster.
Exactly. And a more insidious mechanism involves the loss of the ability to recognize the adducts formed by certain agents, like nitrosoureas and methylating drugs. This often happens because of a defective mismatch repair MMR system. If the cell can't see the damage, it won't trigger the repair or apoptotic pathways.
So ignore the damage.
Essentially, yes. Similarly, a defective cell cycle checkpoint function, maybe due to p53 mutation, as we talked about, can confer resistance to virtually all alkylating drugs. If the cell can't pause its division in response to DNA damage, it just plows ahead, potentially passing on the damage or ignoring the signals for apoptosis.
Then fine.
Finally, impaired apoptotic pathways also contribute significantly to resistance. For example, if the cell overexpresses anti-apoptotic proteins like BCL2, it can effectively prevent itself from undergoing programmed cell death even when faced with significant DNA damage. That's a pretty comprehensive list of how these clever cells develop resistance. It truly is a constant arms race.
It really is. Okay, let's talk about the adverse effects of alkylating drugs, generally speaking. While they are powerful tools, they definitely don't come without significant downsides. This is where that delicate balance between efficacy and toxicity really comes into sharp focus.
Indeed. Alkylating agents, because they target rapidly dividing cells, exhibit predictable patterns of tissue toxicity. These side effects are often the dose-limiting factors that clinicians must carefully manage to maximize the benefit while minimizing harm to the patient.
What's the biggest concern when it comes to healthy tissues? I imagine bone marrow is high on that list, affecting a patient's entire blood system.
Absolutely. Bone marrow suppression, or myelosuppression, is the dose-limiting toxicity for most alkylating agents. This shows up as a significant drop in peripheral blood cell counts, particularly the granulocytes, which are key infection fighters. The nadir, the lowest point, typically occurs around 6 to 10 days after the drug is given, and recovery usually takes place within 14 to 21 days.
Are there differences between the drugs?
Yes, some agents, like busulfan, can cause a more prolonged and cumulative myelosuppression that affects the stem cells themselves. That's actually why it's specifically used in preparative regimens for bone marrow transplantation to wipe out the existing marrow. Beyond just suppressing cell counts, alkylating agents also suppress immunity, which can be useful in autoimmune diseases, but also makes patients vulnerable to opportunistic infections.
And what about other fast-dividing tissues, like the lining of our gut and hair follicles? Those seem like obvious targets, too.
They are. Alkylating agents are typically very toxic to dividing mucosal cells and hair follicles. This leads to common and often distressing side effects like oral mucosal ulceration, known as stomatitis or mucositis, denudation or stripping of the intestinal lining, which can cause severe diarrhea and nutrient absorption problems, and widespread hair loss or alopecia. The mucosal effects are particularly dangerous in high-dose chemotherapy protocols, like those used for bone marrow transplantation, because the breakdown of the gut barrier can predispose patients to life-threatening bacterial infections spreading from the GI tract sepsis.
That sounds serious. What about effects on the nervous system or other major organs?
Nausea and vomiting are very common, almost universal with some older agents like nitrogen mustard, though better controlled now with antiemetics. However, ifosfamide stands out as the most neurotoxic of the common alkylating agents. It can lead to altered mental status, confusion, coma, even seizures, and this is thought to be due to a toxic metabolite called chloroacetaldehyde. Pulmonary fibrosis, or scarring of the lungs, is a potential delayed adverse effect that can be caused by pretty much all alkylating agents, including newer ones like temozolomide. In high-dose regimens, especially with busulfan or BCNU, damage to the lining of liver blood vessels can precipitate veno-occlusive disease, VOD, of the liver, which is a serious and often fatal complication. Fortunately, there's now a treatment, defibrotide, that can sometimes reverse it. Renal failure can occur, particularly after multiple cycles of nitrosoureas or ifosfamide.
And I've definitely heard about specific bladder issues with some of these drugs, like cyclophosphamide.
Indeed, cyclophosphamide and ifosfamide release a toxic metabolite called acrolein as they're broken down. This substance is excreted in the urine and causes severe irritation and bleeding in the bladder wall, known as hemorrhagic cystitis, especially in high-dose regimens. This specific side effect can be effectively prevented, thankfully, by co-administration of a drug called Mesna, which stands for 2-mercaptoethane sulfonate Na+, which chemically neutralizes acrolein in the urine along with vigorous hydration to flush the bladder. Furthermore, the more unstable alkylating agents like the original nitrogen mustard, mechlorethamine, and the nitrosoureas have strong viscant properties. This means they can cause severe tissue damage, blistering, and ulceration if they leak out of the vein during infusion, something called extravasation. Finally, all alkylating agents have significant toxic effects on the reproductive system. They often cause permanent amenorrhea, loss of periods in women, and irreversible azoospermia, lack of sperm production, in men, leading to infertility.
That's a heavy list of potential side effects to manage. And on top of all that, there's the concerning long-term risk of developing another cancer later on, specifically leukemia.
Unfortunately, yes. This is a serious long-term consequence. Alkylating agents have a high capacity to induce leukemia, specifically acute non-lymphocytic leukemia, or AML. This treatment-related AML is often associated with a higher incidence of p53 mutations and characteristic deletions of parts of chromosomes 5 or 7. Its incidence typically peaks about 4 years after therapy ends and can affect up to 5% of patients treated on regimens containing these drugs. Often, this secondary leukemia is preceded by a period of low blood counts, maybe neutropenia or anemia, and a bone marrow appearance consistent with myelodysplasia, a sort of pre-leukemic state. Among the different alkylating agents, melphalan, the nitrosoureas, and procarbazines seem to have the greatest propensity to cause leukemia. This really puts into perspective the difficult risk-benefit calculations that clinicians and patients have to make.
It absolutely does. Okay, let's transition now to the clinical pharmacology of specific alkylating agents. We'll highlight some key drugs to illustrate the principles we've just discussed. We'll kick off with cyclophosphamide. It really seems like a true workhorse in chemotherapy. How does this journey through the body, from absorption to activation, make it so versatile? And what are the main clinical challenges we see with its side effects?
Cyclophosphamide is definitely a cornerstone. It's well absorbed orally, which is a big plus for convenience. Importantly, it's a prodrug, meaning it's inactive until it gets metabolized in the liver, primarily by the CYP2B6 enzyme. This activation step is critical because it produces two crucial molecules: phosphamide mustard, which is the active anti-tumor agent, and acrylane, the toxic metabolite we just discussed that's responsible for hemorrhagic cystitis.
Right, double-edged sword of activation.
Exactly. Because it's eliminated mainly by hepatic metabolism, kidney problems don't typically require a dose adjustment, but liver dysfunction does. Cyclophosphamide has a remarkably broad spectrum of activity. It's essential in treating non-Hodgkin lymphomas, other lymphoid cancers, breast and ovarian cancers, and many pediatric solid tumors. Plus, its potent immunosuppressive properties make it valuable in treating various severe autoimmune disorders, like Wegener's granulomatosis.
Speaking of adverse effects, you already highlighted the hemorrhagic cystitis. What else should clinicians and patients be particularly aware of with cyclophosphamide?
Well, the hemorrhagic cystitis caused by acrolein is a major concern, especially with higher doses. Patients undergoing high-dose treatment absolutely must receive vigorous intravenous hydration and often the protective agent mesna to prevent it. At very high doses, cyclophosphamide can also cause a rare syndrome of inappropriate ADH secretion, leading to water intoxication. And while less common than with some other agents, cardiac toxicities, including a dangerous condition called hemorrhagic myocardial necrosis, can occur, particularly at those very high doses used in transplant settings. It also carries the general risks of myelosuppression, infertility, and secondary leukemia we discussed earlier.
Okay, moving on to efosfamide, which you mentioned is structurally similar to cyclophosphamide. How does it differ in practice?
Efosfamide is indeed an analog of cyclophosphamide. Its activation, primarily by hepatic CYP3A4, is actually slower. This leads to the generation of more of those toxic byproducts, particularly chloroacetaldehyde, which explains its higher rate of neurotoxicity compared to cyclophosphamide. It also tends to cause greater platelet suppression and more nephrotoxicity or kidney damage. It's approved for treating relapsed germ cell testicular cancer and various sarcomas, often used in high-dose chemotherapy regimens requiring stem cell rescue. And just like cyclophosphamide, it always requires co-administration with mesna and vigorous hydration to prevent bladder toxicity. Methylene blue has also been used sometimes to try and manage its CNS toxicity.
Got it. You mentioned several other important alkylating agents earlier. Can you quickly highlight the primary uses or distinguishing features of a few more just to round out the picture?
Certainly. Let's see. Melphalan is predominantly used in treating multiple myeloma, both in standard doses and in high-dose regimens with marrow transplantation. Chlorambucil was historically very important for chronic lymphocytic leukemia, CLL, because it's well tolerated orally at low daily doses, though newer targeted agents are often preferred now. Bendamustine is interesting. It has a unique purine-like structure combined with nitrogen mustard groups. It produces DNA crosslinks that seem to be repaired more slowly by cells. Crucially, it often lacks cross-resistance with classical alkylators, making it valuable for CLL and non-Hodgkin lymphomas that have become refractory to standard treatments.
Okay, great overview. Now let's turn our attention specifically to the alkyl sulfonates, focusing on busulfan. What's its primary role today, given that targeted therapies have taken over in CML?
Busulfan's primary action is profound myelosuppression, particularly affecting stem cells at higher doses. While historically used for controlling chronic myelocytic leukemia, CML, its role there has largely been supplanted by tyrosine kinase inhibitors like imatinib. Today, busulfan is primarily used in high-dose chemotherapy regimens as a preparative or conditioning agent before hematopoietic stem cell transplantation. Its clearance can vary considerably between patients, so therapeutic drug monitoring, adjusting the dose based on measured blood levels, is common to balance efficacy and toxicity. This is particularly important because of the significant risk of hepatic veno-occlusive disease, VOD, if exposure is too high.
Interesting. Any other key toxicities?
Yes, high-dose busulfan can also cause seizures, so patients receiving it typically require prophylactic anticonvulsant medication. And long-term use, though less common now, is associated with that distinctive pulmonary fibrosis, often called busulfan lung.
Right. Next on our list are the nitrosoureas. I know these are particularly important for crossing the blood-brain barrier and treating brain tumors.
That's exactly right. The nitrosoureas, particularly carmastine, BCNU, and lomastine, CCNU, are highly lipophilic, meaning they dissolve well in fats. This property allows them to readily cross the blood-brain barrier, which most chemotherapy drugs cannot do effectively. This makes them crucial agents in the treatment of malignant gliomas, like glioblastoma. They work by alkylating DNA, often at the O6 position of guanine, and their effectiveness can be influenced by the tumor's expression level of the DNA repair enzyme MGMT. Tumors where the MGMT gene promoter is methylated and thus silenced tend to be more sensitive.
What are the main drawbacks of these drugs?
Their main drawback is profound and notably delayed myelosuppression. Unlike most alkylators where counts drop within a week or two, the nadir with nitrosoureas might not occur until 4 to 6 weeks after a single dose, and recovery can be slow. They are also highly carcinogenic themselves. Streptozocin is a unique nitrosourea. It has a glucose molecule attached, giving it a high affinity for the insulin-producing islet cells of the pancreas. This makes it useful specifically in treating metastatic pancreatic islet cell carcinoma.
Fascinating specificity. Now let's explore the triazines, dorarbazine or DTIC, and temozolomide.
Okay, dacarbazine, DTIC, is a methylating agent, but it requires metabolic activation in the liver via CYP enzymes to form its active intermediate, MTIC. It kills cells in all phases of the cell cycle. Resistance often involves the MGMT repair pathway removing the methyl groups. Its primary indication nowadays is usually within combination regimens for Hodgkin disease, like the ABVD regimen. It has modest activity against malignant melanoma and adult sarcomas, although newer immune therapies have largely taken over for melanoma. A major side effect is severe nausea and vomiting in almost all patients.
And temozolomide, that one sounds more targeted for brain tumors.
Exactly. Temozolomide is particularly significant because it's become the standard of care agent, typically given with radiation therapy, for patients with high-grade malignant gliomas. Unlike DTIC, temozolomide undergoes spontaneous, non-enzymatic chemical conversion in the body to that same active metabolite, MTIC. This bypasses the need for liver activation and allows it to readily cross the blood-brain barrier. It's generally more active in tumors that are deficient in the MGMT repair enzyme. Its toxicities mirror DTIC's, mainly myelosuppression.
Let's turn our attention briefly to methylhydrazines, specifically procarbazine.
Procarbazine is another agent used in treating malignant brain tumors and also historically in Hodgkin disease combination regimens like MOPP. It's converted by liver enzymes, CYPs, into highly reactive alkylating species that methylate DNA, leading to chromosomal damage like breaks and translocations consistent with its known mutagenic and carcinogenic actions. Resistance often involves increased MGMT expression. A key clinical point for procarbazine is its unique drug interactions. It's a weak monoamine oxidase, MAO, inhibitor, so it can provoke dangerous hypertensive reactions if combined with certain foods high in tyramine or sympathomimetic drugs. It also has desulfuram-like actions, meaning patients must strictly avoid alcohol. And, as mentioned, it's notably highly carcinogenic itself, contributing significantly to the secondary leukemia risk seen with regimens like MOPP.
Wow, lots of precautions needed there. Finally, in this first major section, let's delve into the platinum coordination complexes. Their discovery story is quite remarkable, isn't it?
It truly is one of the classic serendipitous discoveries in medicine. The growth inhibitory effect of cisplatin was initially observed during studies on how electrical fields affected bacterial growth. They were using platinum electrodes and noticed that something leaching from the corroding electrodes was stopping the bacteria from dividing. That something turned out to be cisplatin. Further studies showed it had potent anti-cancer activity in mouse models, leading to its FDA approval in 1978. Since then, platinum complexes cisplatin, carboplatin, oxaliplatin have become foundational treatments for a very broad range of cancers, including ovarian, testicular, head and neck, bladder, esophageal, lung, and even some colon cancers. And as we discussed, while they don't formally alkylate DNA in the chemical sense of adding an alkyl group, they do covalently bind to nucleophilic sites on DNA, sharing many pharmacological attributes and downstream effects with the classical alkylators.
So how exactly do these platinum complexes work once they get inside the cell? What's the core mechanism of action that makes them so effective?
Okay, the platinum complexes typically enter cells via copper transporters, particularly one called CTR1, and potentially others. Once inside the cell, where the chloride concentration is much lower than in the bloodstream, the chloride ligands, or other groups like oxalate and oxaliplatin, are displaced by water molecules. This process is called equation. This equation yields a positively charged, highly reactive platinum species. This activated form readily reacts with electron-rich regions in the cell, especially on DNA, forming strong covalent bonds, primarily at the N7 position of guanine and adenine bases.
And these bonds form the adducts you mentioned.
Exactly. They form both intrastrand crosslinks, linking two bases on the same DNA strand, and interstrand crosslinks, linking bases on opposite strands. These DNA platinum adducts are highly disruptive. They physically distort the DNA helix, which inhibits critical processes like DNA replication and transcription. This damage can lead to single and double-stranded breaks and cause miscoding during replication attempts. If these lesions are recognized by the cell's damage surveillance systems, like p53 and other cell-cycled checkpoint proteins, they can trigger apoptosis, leading to cell death. The formation and persistence of these adducts are generally considered important predictors of clinical response.
Do the different platinum analogues, cisplatin, carboplatin, and oxaliplatin, form exactly the same types of adducts, or are there subtle but important differences between them?
There are crucial differences, and understanding these is key to understanding their different clinical profiles and patterns of resistance. While all form DNA adducts, the specific analogues differ in their precise conformation and the effects they have on DNA structure. For example, oxaliplatin's adducts are notably bulkier and seem to be less readily repaired by the cell's main repair mechanism for these types of lesions, the nucleotide excision repair, NER system. And perhaps most importantly, oxaliplatin's cytotoxicity does not appear to depend on an active mismatch repair, MMR system, unlike cisplatin and carboplatin. This is a key differentiator and might explain its greater activity in colorectal cancer, where NMR defects are relatively common. This really highlights a powerful insight. Understanding these subtle molecular differences in drug action allows us to potentially target specific cancer vulnerabilities more effectively.
That's a great example of exploiting tumor-specific defects. Given how effectively these drugs attack DNA, it's not surprising that cancer cells develop resistance. What are the main ways cells learn to resist platinum analogues?
Resistance to platinum analogues is definitely multifactorial, and it's a major clinical challenge. Key factors include decreased intracellular drug accumulation, often due to reduced uptake, maybe less CTR1 transporter, or more commonly, increased efflux by pumps like ATP7A and ATP7B, which are copper exporters that unfortunately also pump out platinum. Overexpression of these transporters has been correlated with poor survival after cisplatin therapy. Another mechanism is increased intracellular levels of thiols, especially glutathione, and metal-binding proteins called metallothioneins. These molecules can bind to and effectively inactivate the platinum drug before it reaches the DNA. And finally, altered rates of repair of the DNA adducts. Enhanced activity of the nucleotide excision repair NER pathway, which is responsible for removing these bulky adducts, can confer resistance. Conversely, defects in NER can increase sensitivity.
It's a complex picture. Let's delve into cisplatin specifically now. Its absorption, distribution, metabolism, excretion, ADME, its key therapeutic uses, and its particularly notorious side effects.
Cisplatin is always administered intravenously. And crucially, to prevent its notorious nephrotoxicity, kidney damage, it's absolutely essential to establish what's called a chloride diuresis before treatment starts. This involves giving the patient large volumes of intravenous normal saline. Sometimes a protective agent called amifostine is also used. Therapeutically, cisplatin is a cornerstone treatment. It achieves cure rates of 90% or more in testicular cancer patients when used in combination regimens, like with bleomycin and epitoside. It also induces complete responses in a majority of ovarian carcinoma patients, often with a taxane like paclitaxel. And it's highly effective in bladder, head and neck, lung, and cervical cancers, often used concurrently with radiation therapy because it sensitizes cells to radiation damage.
Now, for its adverse effects, I know nephrotoxicity is the big one everyone talks about.
Nephrotoxicity is definitely a major concern, but it's largely manageable with aggressive hydration and careful monitoring. Other significant and often dose-limiting side effects include ototoxicity, hearing loss, particularly high-frequency loss, and tinnitus, ringing in the ears. Unfortunately, this is often irreversible and not prevented by hydration. Marked nausea and vomiting occur in almost all patients, but thankfully can usually be well controlled with modern antiemetic drug combinations, like 5-HT3 antagonists and NK1 antagonists. At higher cumulative doses or after multiple cycles, cisplatin can cause a progressive peripheral neuropathy, typically sensory, starting in the hands and feet. Stocking glove distribution. This can be quite disabling and may even worsen for a time after the drug is stopped. Myelosuppression is usually mild to moderate. Electrolyte disturbances are very common, particularly hypomagnesemia, low magnesium, but also low calcium, potassium, and phosphate. Routine magnesium monitoring and replacement are standard practice, and like alkylators, there's a long-term risk of secondary leukemia.
Okay. How does carboplatin compare? Is it just a gentler version of cisplatin?
Carboplatin shares similar mechanisms of action and clinical activity spectrum with cisplatin, but it's chemically less reactive. This translates into it being generally much better tolerated clinically. It causes significantly less nausea and vomiting, less neurotoxicity, less ototoxicity, and importantly, much less nephrotoxicity than cisplatin. However, its main dose-limiting toxicity is myelosuppression, specifically thrombocytopenia, low platelets. It's considered equally effective as cisplatin for certain cancers like ovarian and non-small cell lung cancer, and it's often used as an alternative for patients who can't tolerate cisplatin due to pre-existing kidney problems, hearing loss, neuropathy, or refractory nausea. Dosing for carboplatin is often calculated using a formula, like the Calvert formula, that targets a specific area under the curve, AUC, based on the patient's kidney function, creatinine clearance, aiming to optimize the dose for efficacy while managing the myelosuppression risk.
That makes sense. Finally, let's cover oxaliplatin again briefly, just to reinforce its unique characteristics, especially regarding its efficacy in colorectal cancer.
Right. Oxaliplatin is pharmacologically distinct from the other platinum agents. It shows particular efficacy in colorectal and gastric cancers. As we discussed, its effectiveness in colorectal cancer is thought to stem, at least in part, from its cytotoxicity not depending on an active mismatch repair MMR system, which is a significant advantage in colorectal cancers where MMR defects are common. It also appears to suppress thimetylate synthase, TS expression, which promotes synergy with 5-fluorosyl 5-FU. It's a standard component of combination regimens like FO-Ulfox, 5-FU, leucovorin, oxaliplatin for colorectal cancer. Its distinct dose-limiting toxicity is peripheral neuropathy. This neuropathy has two forms. An acute form, often triggered by exposure to cold liquids or air, causing transient paresthesias or dysesthesias, abnormal sensations, in the extremities, mouth, and throat. An accumulative form, similar to cisplatin sensory neuropathy, causing persistent numbness, tingling, and sometimes ataxia, which becomes more common and severe with increasing total dose.
Okay, that wraps up our deep dive into the alkylating agents and platinum complexes. Now let's transition to our second major category of drugs, antimetabolites. These compounds, as the name suggests, interfere with the very building blocks the metabolites needed for synthesizing DNA and RNA. Can you give us a general overview of how this group works?
Absolutely. Antimetabolites are a really diverse group of drugs, but they all exert their anti-cancer effects by somehow inhibiting the proper synthesis or function of nucleic acids, RNA, and DNA. They generally do this through one of two main strategies. Some, like the fluoropyrimidines or the 6-thiopurines, act by directly inhibiting key enzymes involved in the synthesis of essential DNA precursors, the nucleotide building blocks. Others actually mimic the natural building blocks closely enough that they become incorporated into the DNA or RNA molecule itself during synthesis. Once incorporated, these fraudulent bases disrupt the structure and function of the nucleic acid, blocking replication or transcription, and ultimately leading to cellular dysfunction or death. Think of them as sophisticated imposters tricking the cell's machinery into using faulty components.
You mentioned 5-fluorosyl, or 5-FU, as an example earlier when discussing oxaliplatin combinations. Can you elaborate now on its specific mechanisms of action and maybe touch on its common oral prodrug, capecitabine?
Certainly. 5-fluorosyl 5-FU is a classic antimetabolite, a cornerstone in treating colorectal and other GI cancers, as well as breast cancer. It requires enzymatic conversion within the cell to its active nucleotide forms to exert its effects. One critical pathway involves its conversion to 5-fluorodyne triphosphate, FUTP, which gets incorporated into RNA. This incorporation causes major disruptions in RNA processing and function. Perhaps its most well-known mechanism involves its conversion to fluorodeoxyuridine monophosphate, or FDUMP. This FDUMP, along with a folate cofactor, specifically 5010-methylene tetrahydrofolate, forms a very stable covalent ternary complex with the enzyme thimetylate synthase, or TS.
Blocking TS.
Exactly. TS is the enzyme responsible for synthesizing thymidine monophosphate, DTMP, which is then converted to DTTP, an essential building block specifically for DNA. By forming this stable inhibitory complex, FDUMP effectively blocks TS, leading to a depletion of DTTP, thereby starving the rapidly dividing cancer cell of a vital DNA building block and inhibiting DNA synthesis. 5-FU metabolites can also be incorporated into DNA itself as FDUTP, especially when DTTP levels are low. This fraudulent incorporation, along with the accumulation of another nucleotide, DUTP, behind the block TS, can trigger DNA repair attempts. However, because there's no TTT available for the repair patch, these attempts can lead to DNA strand breakage and fragmentation.
Multiple mechanisms of attack then. How do cancer cells develop resistance to 5-FU?
Resistance is common and can occur through several mechanisms. These include the loss or decreased activity of the enzymes needed to activate 5-FU in the first place. Cells can also amplify the gene for TS or develop mutations in TS that make it less sensitive to inhibition by FDUMP. Another important factor is the level of degradative enzymes, particularly dihydropyrimidine dehydrogenase, DPD, which is the primary enzyme responsible for breaking down 5-FU in the body. High levels of DPD in the tumor or liver can reduce the drug's effectiveness. And here's a critical clinical insight. There's a well-known inherited deficiency in DPD activity in a subset of the population. Patients with DPD deficiency metabolize 5-FU much more slowly, leading to greatly increased drug levels and a high risk of severe, potentially fatal toxicity. Testing for DPD deficiency before starting 5-FU-based therapy is becoming increasingly common to identify these patients and adjust doses accordingly or choose alternative therapies.
That's a vital point about DPD. Now, I've often heard about 5-FU being combined with leucovorin. You mentioned leucovorin rescue with methotrexate. Is this a similar idea?
It's related, but actually works in the opposite way here. The combination of 5-FU with leucovorin is a classic example of biochemical modulation designed to enhance 5-FU's action. Leucovorin, or its active form, 5-formyl tetrahydrofolate, is converted intracellularly to 5,010 methylene tetrahydrofolate, that folate cofactor needed to stabilize the FDU-MPTS complex. By providing an excess of this cofactor, leucovorin promotes the maximal formation and stabilization of the inhibited ternary complex, thereby enhancing and prolonging the inhibition of TS and increasing 5-FU's cytotoxic effects. It doesn't rescue normal cells here, it makes the 5-FU work better against the cancer cells. 5-FU, often with leucovorin and oxaliplatin, FOO or X, or irinotecan, LFOY, is a critical component of adjuvant and metastatic therapy for colorectal cancers. It's also a potent radiosensitizer, used with radiation for cancers like anal, rectal, and head and neck. Capecitabine is an orally administered prodrug of 5-FU. It undergoes a series of enzymatic conversions, including by an enzyme called thymidine phosphorylase, which is often present at higher levels in tumors compared to normal tissues, to ultimately generate 5-FU within the tumor site. It's approved for metastatic breast and colorectal cancer.
And what are the main adverse effects we should be aware of for 5-FU and capecitabine?
The earliest warning signs of toxicity often involve the GI tract: anorexia, nausea, and particularly stomatitis, mouth sores, and diarrhea. These can be reliable indicators that a sufficient dose has been reached, and if they become severe, they necessitate stopping the drug. Mucosal ulcerations throughout the GI tract can lead to severe problems, especially in DPD-deficient patients. Myelosuppression, particularly leukopenia, is also a major effect, especially with bolus dose regimens. Alopecia, skin changes, and nail changes can occur. Hand-foot syndrome, also known as palmar-plantar erythrodysesthesia, is particularly prominent with capecitabine and continuous infusional 5-FU regimens. It involves redness, swelling, pain, tingling, and sometimes blistering and peeling of the palms and soles, and it can be dose-limiting. Acute chest pain, potentially due to coronary artery vasospasms, can also occur, though less commonly.
Okay, let's zoom in now on folic acid analogs. Methotrexate, or MTX, is the big name in this category. How does it specifically work its magic, or rather its disruption?
Methotrexate's primary mechanism of action targets an absolutely crucial enzyme in folate metabolism: dihydrofolate reductase, or DHFR. DHFR is responsible for reducing dihydrofolate back to tetrahydrofolate, FH4, which is the active form required for various metabolic reactions. By potently inhibiting DHFR, MTX causes a depletion of intracellular FH4 cofactors. These cofactors in different forms, like N5000, N10 methylene FH4, and N10-formyl FH4, are essential one-carbon donors needed for the synthesis of thymidylate, the T in DNA, and purines, the A and G, in both DNA and RNA. So by blocking DHFR, MTX effectively cripples both DNA replication and RNA synthesis by cutting off the supply of essential building blocks.
That sounds incredibly effective. But you mentioned something else, polyglutamation. What's that about?
Yes, that's a really important aspect of MTX's action and contributes significantly to its potency and selectivity. Like naturally occurring folates, MTX undergoes polyglutamation inside cells. This means that additional glutamate residues are added onto the MTX molecule by an enzyme called polyglutamate synthetase, FPGS. These polyglutamated forms, MTXPGs, have two key consequences. First, they are much more highly charged, which effectively traps them inside the cell. It's a form of ion trapping that leads to prolonged intracellular drug retention. Second, these MTXPGs dramatically increase MTX's inhibitory potency, not just for DHFR, but for additional folate-dependent enzymes, including thymidylate synthase, TS itself, and enzymes involved in the early steps of purine biosynthesis.
So it gets trapped inside and hits multiple targets harder.
Exactly. This intracellular retention and multi-target inhibition by the polyglutamate forms is key to MTX's prolonged and potent effect, particularly in certain tissues and tumor types.
That sounds like a very potent mechanism. But if it's so powerful as shutting down essential synthesis, how do we manage its toxicity to normal, rapidly dividing cells? Is there a way to rescue healthy tissues from this onslaught?
That's where the concept of selective toxicity and, more importantly, rescue strategies come into play. MTX, unfortunately, is only partially selective for tumor cells. It also effectively kills other rapidly dividing normal cells, particularly those lining the intestinal epithelium and the hematopoietic cells in the bone marrow. These toxicities are cycle-specific, primarily killing cells during the S phase, the DNA synthesis phase. To counteract these potentially life-threatening toxic effects on healthy tissues, especially when using high doses of MTX, we employ a strategy called leucovorin rescue. Leucovorin, also known as folinic acid or 5-formyl tetrahydrofolate, is essentially a fully reduced active folate coenzyme. When administered after MTX, leucovorin can effectively bypass the blocked DHFR enzyme and rapidly replete the intracellular pool of active FH4 cofactors, particularly in normal cells, which often transport it more efficiently than tumor cells. This effectively terminates MTX's toxic effects in normal tissues without completely compromising its anti-tumor impact, although the timing and dose are critical. It's a brilliant example of differential rescue based on cellular transport and metabolism.
That's clever pharmacology.
Yeah.
Are there newer antifolates that build on this understanding?
Yes, several newer congeners have been developed. Pemetrexed, for example, is a newer antifolate with a distinct peryl pyrimidine structure. It's avidly transported into cells using the reduced folate carrier and others, and is efficiently converted to polyglutamates. These Pemetrexed polyglutamates inhibit not only TS and DHFR, but also another key enzyme in purine synthesis called glycinamide ribonucleotide formyltransferase, GRR. This multi-targeted inhibition gives it a broader spectrum of activity, particularly against non-small cell lung adenocarcinoma, mesothelioma, and ovarian cancer. Its toxicity profile largely mirrors MTX, but it notably causes a prominent skin rash in many patients, which can be mitigated with dexamethasone. A key point with Pemetrexed is the need for concurrent folic acid and vitamin B12 supplementation to prevent severe, unpredictable myelosuppression related to underlying folate pathway issues.
With all these complex steps, transport, activation, polyglutamation, enzyme inhibition, how do cancer cells develop resistance to antifolates like MTX and Pemetrexed?
Resistance can arise from alterations at virtually every known step in their mechanism of action. Common mechanisms include impaired transport of the drug into the cell due to decreased expression or function of transporters like the reduced folate carrier, production of altered forms of DHFR that have a decreased affinity for MTX, meaning the drug doesn't bind as tightly, increased intracellular concentrations of DHFR, the target enzyme. This often happens through gene amplification, where the cell makes multiple copies of the DHFR gene, leading to massive overproduction of the enzyme that overwhelms the drug. Decreased ability to synthesize the polyglutamated forms, MTXPGs, either due to reduced FPGS activity or increased activity of the enzyme that removes the glutamates, gamma-glutamyl hydrolase, GGH. Without polyglutamation, the drug isn't retained as well and doesn't inhibit other targets as effectively. And finally, increased expression of drug efflux transporters, like those in the MRP family, which actively pump the drug back out of the cell. The strategy of using very high doses of MTX, followed by leucovorin rescue, is specifically designed to overcome some of these resistance mechanisms, like impaired transport or high DHFR levels, by achieving very high intracellular drug concentrations, at least transiently.
Methotrexate is truly a cornerstone in several cancer treatments, particularly childhood leukemia. Can you elaborate on its key therapeutic uses and walk us through its primary adverse effects profile?
Absolutely. MTX is critical in the treatment of childhood acute lymphoblastic leukemia, ALL. It's used in nearly all phases: remission induction, consolidation, and long-term maintenance therapy. High-dose MTX HDML, given as infusions over 6-24 hours every few weeks, always followed by leucovorin rescue, is a standard component of curative therapy for all and also for osteosarcoma. The effectiveness of HGML often inversely correlates with how quickly the patient clears the drug. Slower clearance generally means better outcome, but also higher toxicity risk. For maintenance therapy in 8AL, lower doses are typically given weekly, often orally. Intrathecal administration, injecting directly into the cerebrospinal fluid, is crucial for treating or preventing the spread of leukemia or lymphoma to the central nervous system, meningeal leukemia lymphoma, as systemic MTX penetrates the blood-brain barrier poorly. MTX is also one of the most effective single agents for choriocarcinoma, a rare cancer arising from placental tissue, often achieving cures. It's also a component of regimens for various other cancers like Burkitt lymphoma, breast cancer, and head and neck cancer. And beyond cancer, low-dose MTX is a widely used immunosuppressant for autoimmune diseases like rheumatoid arthritis and psoriasis.
And the downsides. What are the major toxicities we need to monitor for?
The primary dose-limiting toxicities of MTX relate to its effects on rapidly dividing normal tissues. Profound bone marrow suppression, leading to leukopenia, thrombocytopenia, anemia, and damage to the intestinal epithelium, causing mucositis, diarrhea. These can lead to serious risks of hemorrhage and life-threatening infections, requiring careful monitoring, blood transfusions, and antibiotics. These toxicities usually reverse within about 2 weeks after stopping the drug, but can be prolonged and severe if renal function is compromised, delaying MTX excretion. Dose reduction is essential for patients with reduced creatinine clearance. Other common toxicities include alopecia, hair loss, dermatitis, and sometimes an allergic interstitial pneumonitis. Nephrotoxicity is a major risk with high-dose regimens, primarily due to precipitation of MTX, which is a weak acid, in the acidic environment of the renal tubules. This risk is minimized by aggressive hydration and alkalinization of the urine, keeping the pH above 7.0 before and during the infusion. If MTX levels remain high after the infusion, for example 1 micromolar at 48 hours, higher doses of leucovorin are given until the plasma MTX level falls below a safe threshold, like 50 nanomolar. The enzyme glucarpidase is FDA approved as an antidote for toxic MTX levels. It rapidly breaks down MTX in the plasma, though it doesn't affect intracellular or CSF levels much. Intrathecal MTX can cause chemical arachnoiditis, meningismus, headache, and rarely more severe neurotoxicity like seizures or coma. Importantly, leucovorin does not reverse this neurotoxicity. Long-term, low-dose MTX, especially in psoriasis patients, carries a risk of liver fibrosis or cirrhosis.
That's a very thorough picture, thank you. Let's move now to cytidine analogues. Cytarabine, or Ara-C, sounds like it's exceptionally important for acute myeloid leukemia, AML.
That's absolutely right. Cytarabine, cytosine arabinoside, or Ara-C, is arguably the most important antimetabolite used in the treatment of AML. It remains the single most effective agent for inducing remission in AML patients. Its mechanism of action is quite elegant. It's an analog of the natural DNA building block, 2-hydroxycytidinin. Once inside the cell, transported mainly by the ENT1 transporter, it needs to be activated by phosphorylation. The key rate-limiting step is the first phosphorylation carried out by the enzyme deoxycytidine kinase, DCK. Once phosphorylated to ARA-CMP, it's further converted to the active triphosphate form, ARA-CTP. This active ARA-CTP then competes with the natural building block, DCTP, for incorporation into DNA by DNA polymerases during replication. Once incorporated, the ARA-CMP residue within the DNA strand acts as a potent inhibitor of further DNA chain elongation by DNA polymerase, effectively blocking DNA replication and repair, leading to strand breaks and triggering apoptosis. The amount of Ara-C incorporated into DNA generally correlates well with its cytotoxicity.
So it gets mistaken for a real building block, but then jams the machinery. How is Ara-C typically administered, given it's so central to AML therapy, and what are its main adverse effects?
Because it's rapidly broken down in the GI tract and the liver by an enzyme called cytidine deaminase, Ara-C has very poor oral bioavailability and must be given intravenously. It has a very short plasma half-life, around 10 minutes, so it's often given either as a continuous intravenous infusion over several days or as repeated high-dose bolus injections every 12 hours for several days, so-called HIDAC regimens, to ensure sustained exposure of leukemic cells during their S phase. High-dose regimens have significantly improved remission rates and outcomes in certain subtypes of AML. For treating leukemia in the CNS, standard IV doses don't achieve adequate levels, so it can be given intrathecally. A special depot liposomal formulation, Topoisomerase, is available that provides sustained release of Ara-C into the cerebrospinal fluid over about 2 weeks, reducing the need for frequent, painful lumbar punctures. Its main adverse effects are predictable given its mechanism. Acute severe myelosuppression, leukopenia, thrombocytopenia, anemia with characteristic megaloblastic changes in the marrow is the major dose-limiting toxicity. GI disturbances, nausea, vomiting, diarrhea, stomatitis, and conjunctivitis are common. Reversible liver enzyme elevations can occur. A serious, though less common, toxicity particularly associated with high-dose Ara-C is non-cardiogenic pulmonary edema, fluid in the lungs, sometimes called Ara-C lung, which can manifest 1–2 weeks after treatment and can be fatal. There's no specific therapy other than stopping the drug and providing respiratory support. Neurological toxicity can also occur, especially with intrathecal or high-dose systemic therapy. This can range from cerebellar toxicity, ataxia, slurred speech, to seizures, delirium, dementia, and even coma. The risk is higher in patients over 50 or those with poor renal function.
Okay, let's discuss azacitidine and decitabine next. I understand these drugs have a unique mechanism related to altering DNA methylation patterns, acting as epigenetic modifiers.
Yes, these azonucleosides, azacitidine, 5-azacitidine, and decitabine, 2-butoxy-5-azacitidine, have fascinating antileukemic activity that goes beyond just direct cytotoxicity. While they are cytotoxic at higher doses, by incorporating into DNA and RNA and inhibiting synthesis, their more unique action, particularly at lower clinically used doses, is to induce differentiation in leukemic cells by inhibiting DNA methylation. They get incorporated into DNA, and once there, they covalently trap the enzyme DNA methyltransferase, DNMT. This leads to depletion of the active enzyme and results in a global hypomethylation of the DNA. Methylation patterns are crucial epigenetic regulators of gene expression, and this drug-induced hypomethylation can lead to the re-expression of silenced tumor suppressor genes or differentiation-promoting genes, ultimately causing tumor cell differentiation, growth arrest, and apoptosis. Both drugs are approved for treating myelodysplastic syndromes, MDS, a group of pre-leukemic bone marrow disorders. Azacitidine, in particular, has been shown to improve overall survival in higher-risk MDS patients. They are typically given subcutaneously or intravenously over several days in repeating cycles. Their main toxicity is myelosuppression.
Very interesting approach, reprogramming the cell's gene expression. Next, let's explore gemcitabine, which you mentioned is a defluoroanalog of deoxycytidine.
Gemcitabine, DFDC, is another important cytidine analog, widely used in treating solid tumors like pancreatic cancer, a standard first-line agent for many years, non-squamous, non-small cell lung cancer, ovarian, breast, and bladder cancer. Like Ara-C, it enters cells via nucleoside transporters, ENT1 being major, and requires activation by phosphorylation, primarily by DCK, to its monophosphate, DFDCMP, and then further to its didomain triphosphate forms, DFDCTP, DFDCTP. Its cytotoxicity isn't strictly confined to the S phase. It has multiple actions on DNA synthesis. The triphosphate, DFDCTP, can incorporate into DNA, but once incorporated, it allows only one more nucleotide to be added before causing masked chain termination, effectively halting DNA elongation in a way that's resistant to repair. The diphosphate, DFDCTP, is also a potent inhibitor of ribonucleotide reductase, RNR, the enzyme that generates the deoxyribonucleotide building blocks, thus depleting the pools needed for DNA synthesis. This RNR inhibition self-potentiates gemcitabine's own incorporation into DNA. Gemcitabine is inactivated by cytidine deaminase. Its principal dose-limiting toxicity is myelosuppression, which tends to be greater with longer infusion times. Non-hematological toxicities include a common flu-like syndrome, fatigue, asthenia, mild liver enzyme elevations, and rarely serious conditions like interstitial pneumonitis or hemolytic uremic syndrome. Importantly, gemcitabine is a very potent radiosensitizer, so extreme caution is needed when combining it with radiation therapy.
Excellent. Let's move now to the final group within antimetabolites, the purine analogues. This seems like another diverse group with significant roles in leukemia and lymphoid malignancies.
Indeed. These are structural analogs of the naturally occurring purine bases, adenine and guanine, and possess significant antileukemic and immunosuppressant properties. This category includes well-known drugs like the 6-thiolpurine, 6-MP, 6-TG, as well as newer agents like fludarabine, cladribine, clofarabine, nalurabine, and pentostatin. Many of these show an apparent selectivity for lymphoid tissue, perhaps related to the expression levels of activating enzymes or transporter proteins within lymphocytes.
Let's start with the classic 6-thiopurine analogs, 6-mercaptopurine, 6-MP, and 6-thioguanine, 6-TG. These have been around for a while.
Yes, 6-mercaptopurine, 6-MP, and 6-thioguanine, 6-TG are analogs of the natural purines hypoxanthine and guanine, respectively, with sulfur replacing an oxygen atom on the purine ring. They are crucial drugs in treating human leukemias, particularly all. They enter cells readily and must be activated intracellularly by the enzyme hypoxanthine guanine phosphorybossyl transferase, HGPRT, which converts them into the respective ribonucleotide forms 6-thioguanosine monophosphate, TAMP, from 6-MP, and 6-thioguanosine monophosphate, 6-thioGMP from 6-TG. These active thiopurine nucleotides then exert their effects through multiple mechanisms. They inhibit de novo purine synthesis at several steps, particularly the very first committed step involving the enzyme glutamine PRPP aminotransferase. This inhibition leads to a shutdown of the production line for normal adenine and guanine nucleotides. Additionally, the 6-thioguanine nucleotide, after further conversion to the triphosphate, can be incorporated into DNA, where it disrupts DNA structure and function, inducing strand breaks and base mispairing during replication.
You mentioned metabolism being key for 6-MP earlier regarding interactions. Can you elaborate on the ADME and toxicity, especially the role of TPMT?
Right, both 6-MP and 6-TG have incomplete and variable oral absorption. A crucial point for 6-MP is its significant first-pass metabolism in the liver by the enzyme xanthine oxidase, which converts it to inactive 6-theoric acid. This is why the dose of oral 6-MP must be dramatically reduced by about 75% if the patient is also taking allopurinol, a xanthine oxidase inhibitor often used for gout or tumor lysis syndrome. This interaction doesn't apply to 6-TG or intravenous 6-MP. Another major metabolic pathway for both drugs is methylation by the enzyme thiopurine S-methyltransferase, TPMT. TPMT activity is genetically polymorphic in the population. About 10–15% of Caucasians and African Americans have intermediate TPMT activity, heterozygotes, and about 1 in 300 individuals have very low or absent TPMT activity, homozygous deficient. Patients with reduced TPMT activity metabolize thiopurines much more slowly, leading to accumulation of the active nucleotides and a greatly increased risk of severe life-threatening myelosuppression if standard doses are used. Conversely, patients with high TPMT activity might metabolize the drug too quickly, potentially reducing efficacy. Genetic testing or phenotypic testing for TPMT activity is now recommended before starting thiopurine therapy, especially for non-malignant conditions like inflammatory bowel disease, to allow for appropriate dose adjustments. 6-MP is a mainstay in the maintenance therapy of ALL, often used in combination with methotrexate. Its principal dose-limiting toxicity is myelosuppression, which can be delayed and severe, especially in TPMT-deficient individuals. Other side effects include anorexia, nausea, vomiting, and potential liver toxicity, jaundice, enzyme elevations.
That TPMT story is a perfect example of pharmacogenetics impacting therapy. What about some of the other key purine analogues? Fludarabine sounds important for CLL.
Yes, fludarabine phosphate is a fluorinated analog of another antiviral purine nucleoside, virabine. It's highly active in chronic lymphocytic leukemia, CLL, and low-grade non-Hodgkin lymphomas. It's also a very potent immunosuppressant. It's a prodrug that gets dephosphorylated in the plasma, enters cells, and is then rephosphorylated by DCK to its active triphosphate form. This active form inhibits several key enzymes involved in DNA synthesis, DNA polymerase, DNA primase, DNA ligase, RNR, and also incorporates into both DNA and RNA, causing chain termination and interfering with RNA function. Resistance can occur through decreased DCK activity or increased drug efflux. Clinically, its potent effect on lymphocytes, especially CD4 plus T cells, leads to significant immunosuppression and predisposes patients to opportunistic infections, sometimes long after therapy has ended. It's highly effective in CLL, often used in combination with cyclophosphamide and rituximab, FCR regimen, and also used as an immunosuppressant in non-myeloablative stem cell transplants.
And cladribine.
Cladribine is another purine analog, resistant to degradation by adenosine deaminase, ADA. It is remarkably potent and often curative with a single course in hairy cell leukemia. It's also active in CLL and low-grade lymphomas. Like fludarabine, it's activated by DCK. Its triphosphate incorporates into DNA, causing strand breaks and depleting cellular energy stores, NAD, ATP, leading to apoptosis. Importantly, it's cytotoxic to both dividing and non-dividing lymphocytes, which may contribute to its profound and prolonged immunosuppression. Its major toxicity is myelosuppression and opportunistic infections related to depletion of CD4 plus cells.
Any others we should briefly mention?
Clofarabine is a newer generation purine nucleoside analog designed for enhanced stability and activation, approved for relapsed refractory pediatric AL. It shares mechanisms with cladribine and fludarabine, but has significant toxicities, including myelosuppression and capillary leak syndrome. Nailorabine is unique as the only guanine nucleoside analog in clinical use. It has selective activity against T-cell AL and T-cell lymphoblastic lymphoma, particularly in the relapse setting. It's a prodrug activated to ARIG-GTP, which incorporates into DNA. A major concern is potentially irreversible neurological toxicity. Finally, pentostatin, or deoxycoformycin, is a potent inhibitor of the enzyme adenosine deaminase, ADA. ADA inhibition leads to the accumulation of toxic adenosine and deoxyadenosine nucleotides, particularly in lymphocytes, inhibiting DNA synthesis and causing cell death. It's highly effective in hairy cell leukemia, but largely superseded by cladribine now due to a better toxicity profile. It causes profound and prolonged immunosuppression.
That covers the antimetabolites thoroughly. Now let's explore the fascinating world of natural products used in cancer therapy, starting with the microtubule-damaging agents. These drugs target the very structural skeleton of the cell.
Exactly. These drugs are fascinating because they interfere with microtubules, which are dynamic protein filaments forming a key part of the cell's cytoskeleton. Microtubules are absolutely essential for cell division, particularly during mitosis, where they form the mitotic spindle that segregates chromosomes. But they're also vital for other critical cellular functions, like maintaining cell shape, intracellular transport, like along nerve axons, and cell movement. Targeting microtubules hits cancer cells at a very vulnerable point, their need for rapid division.
Let's kick off with the vinca alkaloids, vinblastine, vincristine, and vinorelbine. Where do these come from, and how do they specifically mess with microtubules?
These are natural alkaloids purified from the common periwinkle plant, Catharanthus roseus. They were among the earliest effective clinical agents discovered for treating leukemias, lymphomas, and testicular cancer. Their mechanism involves binding specifically to botubulin, one of the two protein subunits that make up microtubules. By binding to botubulin, they effectively block its polymerization or assembly with the tubulin into microtubules. This prevents the formation of functional mitotic spindles, leading to an arrest of cell division in metaphase, M phase. Cells stuck in mitosis eventually undergo apoptosis. They are thus highly cell cycle specific. Their characteristic neurotoxicity is thought to relate to the disruption of microtubule functions required for normal axonal transport in nerve cells.
Given they target the same component, do cancer cells develop resistance to these, and do the different vinca alkaloids share that resistance? What about their side effect profiles?
Yes, they generally share cross-resistance. A major mechanism of resistance involves the overexpression of the P-glycoprotein, PGP efflux pump, encoded by the MDR1 ABCB1 gene. PGP is an ATP-dependent transporter that pumps a broad range of structurally diverse drugs, including the vincas, out of the cell, reducing intracellular concentrations below effective levels. Resistance can also stem from mutations in the botubulin protein itself that prevent the drug from binding, or changes in the expression of different tubulin isoforms. Clinically, the different vinca alkaloids have quite distinct toxicity profiles, which dictates their use. Vinblastine is primarily associated with myelosuppression, particularly neutropenia, as its dose-limiting toxicity, with relatively milder neurological side effects. It's famously used in the ABBD regimen for Hodgkin lymphoma and was part of curative regimens for testicular cancer, though often replaced by etoposide now. Vincristine, on the other hand, causes very little myelosuppression, which makes it extremely valuable for use in combination chemotherapy regimens, like CHP for lymphoma or induction therapy for childhood ALL, where marrow toxicity from other drugs is a concern. However, its dose-limiting toxicity is predominantly neurological toxicity. This typically manifests as peripheral neuropathy, numbness, tingling, weakness, loss of reflexes, constipation due to effects on autonomic nerves, and sometimes cranial nerve palsies. This neurotoxicity can be severe and usually requires dose reduction or discontinuation. A critical safety point. Inadvertent injection of vincristine into the cerebrospinal fluid intracathecally is absolutely devastating and almost always fatal due to irreversible coma and seizures. It must only be given intravenously. Vinorelbine is a semi-synthetic vinca alkaloid with activity against non-small cell lung cancer and breast cancer. Its primary toxicity is granulocytopenia, neutropenia, and it generally causes less neurotoxicity than vincristine or vinblastine.
That distinction between vincristin's neurotoxicity and vinblastine's myelosuppression is crucial. Now let's discuss the taxanes, paclitaxel and docetaxel. These also target microtubules, but I understand they work in a completely different, almost opposite way.
That's exactly right, and it's a fascinating contrast. Paclitaxel, taxol, was originally isolated from the bark of the Pacific yew tree, Taxus brevifolia. Docetaxel, caxatir, is a semi-synthetic analog. What makes the taxanes unique is their mechanism. Unlike the vincas, which prevent microtubule assembly, the taxanes bind to a different site on botubulin and promote microtubule polymerization, and crucially stabilize the resulting microtubules, preventing their normal dynamic disassembly. This leads to the accumulation of dysfunctional, hyperstable microtubules and the formation of abnormal microtubule bundles within the cell. This completely disrupts the normal process of mitosis, leading to mitotic arrest and ultimately triggering cell death by apoptosis. So both vincas and taxanes target microtubules and cause mitotic arrest, but through opposing effects on microtubule dynamics, destabilization versus hyperstabilization. Taxanes have become absolutely central components in treating patients with a wide range of solid tumors, including metastatic ovarian, breast, lung, GI, genitourinary, and head neck cancers.
And how do cancer cells become resistant to taxanes given this different mechanism?
Resistance mechanisms overlap somewhat with the vincas, but also have unique aspects. Increased drug efflux via P-glycoprotein, PGP, is again a major factor contributing to resistance for both paclitaxel and docetaxel. However, cabazitaxel, a newer taxane, was specifically designed to be a poor substrate for PGP, making it useful for treating multidrug-resistant prostate cancer that has progressed after docetaxel therapy. Other mechanisms include mutations in the taxane binding site on P-tubulin, upregulation of specific white tubulin isoforms, like pi-3-tubulin, that are less sensitive to taxanes, and alterations in apoptotic signaling pathways, like increased expression of anti-apoptotic proteins like survivin.
Let's break down the main adverse effects for the two mainstays, paclitaxel and docetaxel. Are they similar or distinct?
They have overlapping but also distinct side effect profiles. For paclitaxel, its primary dose-limiting toxic effects are usually on the bone marrow, causing neutropenia, with the nadir typically occurring around day 8-11, followed by fairly rapid recovery. Myalgias and arthralgias, muscle and joint pain, are common. A significant and often dose-limiting toxicity is peripheral sensory neuropathy, manifesting as numbness, tingling, and pain in a stocking glove distribution. This can be disabling, especially in patients with pre-existing diabetic neuropathy or those also receiving platinum agents. Hypersensitivity reactions related to the cremophore vehicle used to dissolve paclitaxel were common with shorter infusions, but are now largely averted by premedication with steroids and antihistamines. A nanoparticle albumin-bound formulation, nab-paclitaxel abraxane, avoids the need for cremophore and has less hypersensitivity and possibly less neuropathy. Docetaxel generally causes more profound neutropenia than paclitaxel at standard doses. It typically causes less severe peripheral neuropathy, but fatigue asthenia can be more pronounced. Hypersensitivity reactions can still occur related to its polysorbate 80 vehicle, but are often less frequent or severe than with standard paclitaxel. A unique and progressive problem specifically associated with docetaxel is fluid retention. This manifests as peripheral edema, weight gain, pleural effusions, fluid around the lungs, ascites, fluid in the abdomen, and sometimes pulmonary edema. This is thought to be due to increased capillary permeability and can be significantly ameliorated by premedication with oral dexamethasone for several days around the infusion.
That fluid retention with docetaxel is a key differentiator. Let's also cover estromustine briefly. It has an interesting structure combining an estrogen and a mustard. How does it actually work?
Estromustine structurally links bestradiol, an estrogen, to nornitrogen mustard. However, importantly, despite its name and structure, it does not function as a significant DNA alkylating agent in vivo. Instead, its primary mechanism involves binding to boat-tubulin and microtubule-associated proteins, MAPs, leading to microtubule disassembly and antimitotic actions, somewhat similar in effect to colchicine or the vinca alkaloids. It's used primarily for the palliative treatment of hormone-refractory progressive or metastatic prostate cancer. Its side effects include myelosuppression, but also significant estrogenic effects like gynecomastia, impotence, and increased risk of thrombosis, blood clots, and fluid retention.
And finally, in this microtubule section, the upalones, with ixpepilone being the key example. Where do these fit in?
The epothalones are a class of natural products, polypeptides, originally isolated from a soil myxobacterium. Ixtapepilone is a semi-synthetic analog approved for treating metastatic breast cancer, particularly cases resistant to other agents. Its mechanism involves binding to the tubulin pocket, actually the same site as the taxanes. Like taxanes, it triggers microtubule nucleation and stabilization, leading to dysfunctional microtubule dynamics, G2M phase cell cycle arrest, and apoptosis. A potential advantage is that ixapepilone appears to be less susceptible to PGP-mediated afflux and some other common mechanisms of multi-drug resistance compared to the taxanes, making it effective in some tumors that have become resistant to taxanes. Its adverse effects profile is quite similar to the taxanes, primarily neutropenia and peripheral sensory neuropathy.
Fascinating how nature provides these complex molecules targeting such a fundamental process. Now let's move on to another group of natural products, the camptolysin analogues. These are potent drugs that target a different crucial nuclear enzyme, topoisomerase of grain.
Indeed, the camptothecins, originally derived from the happy tree, Camptotheca acuminata, are potent cytotoxic agents. The two main approved analogues used clinically are irinotecan and topotecan, which have shown significant activity in cancers like colorectal, ovarian, and small cell lung cancer. They specifically target the nuclear enzyme DNA, topoisomerase I. Topoisomerases are essential enzymes that manage the topology of DNA. They relieve the torsional stress that builds up in the supercoiled DNA helix during processes like replication, transcription, and repair, essentially by cutting and resealing DNA strands. Topoisomerase I does this by introducing transient single-strand breaks in the DNA. Camptothecins work by binding to and stabilizing the normally transient complex formed between topoisomerase I and the cleaved DNA strand. They essentially trap the enzyme in the act of cutting the DNA, preventing the subsequent relegation or resealing step. This leads to an accumulation of these stalled enzyme DNA complexes, known as cleavable complexes, which feature single-stranded DNA breaks.
And it's these single-stranded breaks that lead directly to cell death.
Here's where the mechanism gets really interesting and explains their cell cycle specificity. These single-stranded breaks associated with the trapped topoisomerase I are actually reversible if the drug's removed or the enzyme dissociates. However, the real cytotoxicity arises when an advancing DNA replication fork, the machinery that duplicates DNA during the S phase, collides with one of these stalled cleavable complexes. This collision converts the transient single-strand break into an irreversible, much more lethal double-strand DNA break. It's this catastrophic event, the generation of double-strand breaks specifically during DNA replication, that ultimately triggers checkpoint activation and apoptosis, leading to cell death. Because ongoing DNA synthesis is necessary for this collision event, and thus for cytotoxicity, camptothecins are considered S-phase specific drugs. This also implies that prolonged exposure to drug concentrations above a certain threshold might be more effective than short, high-dose bursts, allowing more cells to enter S-phase and encounter the drug-stabilized lesions.
That collision model is key. Given that powerful S-phase specific mechanism, how do cancer cells develop resistance to camptothecins like irinotecan and topotecan?
Resistance is a significant issue and can occur through several mechanisms. Decreased intracellular drug accumulation is one factor, often due to the overexpression of drug efflux transporters like ABCG2, also known as BCRP or breast cancer resistance protein, which has been shown to pump out both irinotecan and its active metabolite SN38. For irinotecan, which is a prodrug, resistance can also arise from a lack of the activating carboxylesterase enzyme activity within the tumor cells, preventing its conversion to the highly active metabolite SN38, though activation can still occur in the liver and plasma. Other mechanisms include decreased expression or mutation of the target enzyme, topoisomerase I, making it less available or less sensitive to the drug. Cells might also transiently downregulate topoisomerase expression upon prolonged exposure. Mutations that reduce the enzyme's catalytic activity or its ability to bind DNA can also confer resistance. Interestingly, sometimes cells might try to compensate by upregulating topoisomerase II, the enzyme that handles double-strand breaks, potentially providing an alternative way to manage DNA topology when topoisomerase is inhibited.
Let's delve into irinotecan specifically now. It's widely used, especially in colorectal cancer. What are its therapeutic uses and its particularly notorious adverse effects, especially the diarrhea?
Irinotecan is indeed a key drug, primarily used in treating metastatic colorectal cancer, often in combination with 5-FU and leucovorin, in regimens like FOLFIRI, or with targeted agents like cetuximab. It also has activity in small cell lung cancer and pancreatic cancer. A liposomal formulation is approved for pancreatic cancer after gemcitabine failure. As mentioned, it's a prodrug converted to its active metabolite SN38 predominantly by carboxylesterase enzymes, mainly in the liver but also elsewhere. SN38 is significantly more potent than irinotecan itself. Both irinotecan and SN38 undergo further metabolism, including inactivation of SN38 via glucuronidation by the enzyme UGT1A1 to form SN38GA, which is then excreted in bile. This UGT1A1 enzyme is crucial because its activity is highly polymorphic in the population. Individuals with genetic variants leading to reduced UGT1A1 activity, like those with Gilbert syndrome, metabolize SN38 much more slowly. This leads to higher levels of active SN38 and a significantly increased risk of severe toxicity, particularly neutropenia and severe diarrhea. Testing for UGT1A1 polymorphisms, like the UGT1A128 variant, is recommended to identify patients at higher risk who may require dose reductions.
So the genetics directly impacts the toxicity. Tell us more about that diarrhea.
Irinotecan is infamous for causing significant diarrhea, which can occur in two forms: There's an early cholinergic syndrome happening within 24 hours associated with inhibition of acetylcholinesterase, causing acute diarrhea, sweating, salivation, abdominal cramps. This usually responds well to atropine. More problematic is the delayed diarrhea, typically occurring several days after treatment. This is thought to be due to direct damage to the intestinal mucosa by SN38, possibly exacerbated by reactivation of the inactive SN38G metabolite back to SN38 by bacterial enzymes in the gut lumen. This delayed diarrhea can be severe, leading to dehydration, electrolyte imbalances, and even sepsis, and it is often the dose-limiting toxicity. Intensive management with high-dose loperamide is standard practice, but sometimes hospitalization is required. Myelosuppression, particularly neutropenia, is the second most common dose-limiting toxicity. Other side effects include nausea, vomiting, fatigue, alopecia, and transient elevations in liver enzymes.
Okay, that UGT1A1 connection and the severe diarrhea are critical points for irinotecan. Now let's turn our attention to another major class of natural products used as anti-cancer drugs, antibiotics, starting with dactinomycin.
Dactinomycin, also known as actinomycin D, is one of the older anti-cancer antibiotics derived from Streptomyces soil bacteria. It's a type of chromopeptide containing a distinctive planar phenoxazone ring structure. Its primary mechanism of action involves binding tightly to double helical DNA. The planar phenoxazone ring intercalates, meaning it slips in between adjacent guanine-cytosine base pairs of the DNA helix. The attached peptide chains extend along the minor groove, further stabilizing the complex. This stable drug DNA complex physically obstructs the movement of RNA polymerase along the DNA template, thereby blocking the transcription of DNA into RNA. It's particularly potent at inhibiting DNA-dependent RNA synthesis, more so than DNA replication at lower concentrations. It can also cause single-strand breaks in DNA, possibly via free radical generation or interaction with topoisomerase 2. Dactinomycin is highly effective and plays a curative role in certain pediatric solid tumors, particularly Wilms tumor and rhabdomyosarcoma, usually in combination with surgery, radiation, and other chemotherapy agents like vincristine and cyclophosphamide. It's also used for Ewing sarcoma and is part of curative therapy with methotrexate for metastatic choriocarcinoma in adult women. A critical administration concern is that dactinomycin is extremely corrosive to soft tissues, so severe local injury, ulceration, necrosis can occur if the drug extravasates, leaks out of the vein, during intravenous injection. Its main systemic toxicities are nausea, vomiting, myelosuppression, and severe mucositis.
Got it. Potent transcription blocker. Key in pediatric cancers, watch out for extravasation. Now let's cover the very important anthracyclines and the related anthracynodones. This group includes major drugs like doxorubicin, daunorubicin, and metoclongstrone, but they are famously associated with potential heart damage.
Yes, the anthracyclines like doxorubicin and daunorubicin, originally derived from Streptomyces peucetus, are among the most widely used and effective anti-cancer agents ever developed. Related analogues include epirubicin and idarubicin. Methoxytrone is a structurally similar synthetic compound, and anthracynodones. While incredibly effective against a broad range of hematologic malignancies, leukemias, lymphomas, and solid tumors, breast, ovarian, sarcomas, etc., their use is significantly limited by a unique and major toxicity: the potential to cause cardiomyopathy, damage to the heart muscle, which can be cumulative, dose-related, and often irreversible, potentially leading to congestive heart failure. Methoxytrone generally has less cardiotoxicity than the classic anthracyclines.
What are the primary mechanisms by which anthracyclines kill cancer cells, and how do cells become resistant?
Anthracyclines have multiple proposed mechanisms of action. First, like dactinomycin, they can intercalate into DNA, inserting their planar ring structure between base pairs, which physically obstructs DNA replication and transcription. However, a more important mechanism for their cytotoxicity is likely their ability to inhibit topoisomerase 2. They form a stable ternary complex with topoisomerase 2 in DNA, trapping the enzyme after it has created a double-strand break, but before it can reseal the break. This leads to the accumulation of protein-linked double-strand DNA breaks, which are highly lethal lesions that trigger apoptosis. A third major mechanism involves the generation of free radicals. The quinone moiety in the anthracycline structure can undergo redox cycling, interacting with iron and molecular oxygen to produce highly reactive oxygen species, ROS, such as superoxide radicals and hydroxyl radicals. These ROS can directly damage DNA, proteins, and cell membranes, including mitochondrial membranes, contributing to both anti-cancer effects and significantly to cardiotoxicity. The heart muscle seems particularly susceptible to this free radical damage due to lower levels of protective antioxidant enzymes like catalase. Resistance is often mediated by increased drug efflux via P-glycoprotein, PGP, and other ABC transporters like MRP1 and ABCG2, BCRP. Other mechanisms include increased activity of detoxifying enzymes like glutathione peroxidase, decreased topoisomerase 2 activity or mutations in the enzyme, and enhanced DNA repair capacity.
Let's focus specifically on doxorubicin, adriamycin, arguably the most well-known anthracycline, and particularly that unique cardiotoxicity.
Doxorubicin is indeed a workhorse drug, highly effective in treating malignant lymphomas, part of standard regimens like CHOP, breast cancer, both adjuvant and metastatic settings, sarcomas, and many other cancers. It's typically given as an intravenous infusion every 3 weeks. A liposomal formulation is also available, which alters its distribution and may reduce some toxicities, particularly cardiotoxicity. Patients should be warned it often imparts a harmless red color to the urine. Its major dose-limiting toxicity in the short term is myelosuppression, particularly leukopenia. Stomatitis, mucositis, diarrhea, and complete alopecia are also very common and often severe. It can cause a local flare reaction near the infusion site, and like dactynomycin, it's a potent vesicant causing severe tissue damage upon extravasation. It can also cause radiation recall, reactivating skin damage in previously irradiated areas. But the most important long-term toxicity is the cardiomyopathy. This can manifest acutely during or shortly after infusion as transient ECG changes or arrhythmias, or rarely as an acute pericarditis-myocarditis syndrome. More commonly, it presents as a chronic, cumulative, dose-related cardiomyopathy that develops months or even years after treatment. It manifests as progressive congestive heart failure, often refractory to treatment, with a high mortality rate. The risk increases significantly with the total cumulative lifetime dose received, with a generally accepted threshold around 450-550 mmHg beyond which the risk rises sharply, though toxicity can occur at lower doses, especially with risk factors like prior chest radiation or concurrent cardiotoxic drugs, like trastuzumab. To mitigate this risk, cumulative doses are carefully tracked. The cardioprotective agent dexrazoxane, an iron chelator that may also interact with topoisomerase I-beta in cardiac cells, can be used in certain situations, VU in metastatic breast cancer patients receiving high cumulative doses, to reduce the incidence and severity of cardiotoxicity. Monitoring cardiac function, EUG, with echocardiograms or MEGA scans is standard practice for patients receiving anthracyclines.
That cardiotoxicity is a really serious consideration. What about methoxytrone? How does it differ?
Methoxytrone is a synthetic anthracynodione. It's also a topoisomerase II inhibitor and intercalates into DNA, but it has a significantly lower potential to produce quinone-type free radicals compared to doxorubicin. Consequently, it causes substantially less cardiac toxicity, although it's not entirely free of this risk, especially at higher doses. It's used primarily in treating acute myeloid leukemia, AML, advanced hormone-refractory prostate cancer, and also has approval for treating certain forms of multiple sclerosis due to its immunosuppressive effects. Its main toxicities are acute myelosuppression and mucositis. Nausea, vomiting, and alopecia tend to be less severe than with doxorubicin.
Okay, that covers the major antibiotic classes. Let's move on to the epiphytophyllotoxins, primarily etoposide and tenopicide. These target topoisomerase II as well, right?
Yes, etoposide, VP16, and tenopicide, VM26, are semi-synthetic derivatives of podophyllatoxin, a compound originally isolated from the mayapple plant. They are important agents used in treating pediatric leukemia, small cell lung carcinomas, testicular tumors, a key component of curative regimens, and lymphomas. Interestingly, unlike the parent compound, podophyllatoxin, which inhibits microtubule assembly, etoposide and tenopicide at clinically relevant concentrations have little effect on microtubules. Their primary mechanism of action is the inhibition of DNA topoisomerase II. Similar to the anthracyclines, they have formed ternary complexes with topoisomerase II and DNA, stabilizing the cleavable complex where the DNA is cut, but preventing the enzyme from resealing the double-strand break. This leads to an accumulation of protein-linked double-strand DNA breaks, particularly during the S and G2 phases of the cell cycle when topoisomerase II activity is high, ultimately triggering apoptosis. Resistance can occur through amplification or mutation of the MDR1 gene, leading to PGP efflux, or through decreased expression or mutations in topoisomerase II itself. Mutations in the p53 tumor suppressor gene can also confer resistance by impairing the apoptotic response to the DNA damage.
Let's focus on etoposide, as it's more widely used. How is it given, and what are its key side effects, including that concerning secondary leukemia risk?
Etoposide can be given both intravenously and orally, although oral absorption is variable, around 50%. The IV formulation must be administered slowly over 30-60 minutes to avoid hypotension and bronchospasm, which are related to the infusion vehicle. Dose reductions are needed for patients with renal impairment, as a significant fraction is excreted unchanged in the urine. It's a crucial part of curative combination chemotherapy for testicular cancer, for example, BEP regimen, bleomycin, etoposide, cisplatin. It's also standard treatment for small cell lung carcinoma, often with cisplatin or carboplatin. It has activity in non-Hodgkin lymphomas, acute non-lymphocytic leukemia, and Kaposi sarcoma as well. Because its primary acute toxicity is myelosuppression, it has been used in high-dose chemotherapy regimens with stem cell rescue. Recently, a CDK46 inhibitor, trilaciclib, was approved to decrease myelosuppression when given prior to platinum etoposide regimens for small cell lung cancer. Adverse effects include myelosuppression, mainly leukopenia, nadir around 10-14 days, which is typically the dose-limiting toxicity. Nausea, vomiting, stomatitis, diarrhea, and reversible alopecia are also common. A particularly disturbing complication associated with etoposide and other topoisomerase II inhibitors is the development of a specific type of treatment-related acute myeloid leukemia, TAML. This leukemia often features characteristic translocations involving chromosome 11q23, the MLL gene, and typically occurs with a relatively short latency period, often 1 to 3 years, compared to the secondary leukemias seen after alkylating agents. The risk seems higher with prolonged low-dose schedules like weekly or twice-weekly dosing and high cumulative doses.
That secondary leukemia risk is definitely something to be aware of. Now, let's discuss the trabectedin analogs. Trabectedin comes from a very unusual source, a marine invertebrate.
Indeed. Trabectedin was originally isolated from the marine tunicate Actinicidia turbinata, a type of sea squirt. It represents a novel class of anti-cancer agents with a unique mechanism. It functions as an alkylating drug, but in a distinct way. It binds to the minor groove of DNA and alkylates the N2 position of guanine. This binding causes the DNA helix to bend towards the major groove. Here's the really clever part. This bulky DNA adduct is specifically recognized by components of the transcription-coupled nucleotide excision repair NER complex. The cell's attempt to repair this lesion, involving the NER machinery, somehow paradoxically converts the initial adduct into a lethal double-stranded DNA break. So it hijacks the cell's own repair system to create more lethal damage. Its activity seems to be particularly pronounced in cells that have defects in other repair pathways like homologous recombination, HRD, but requires an intact NER system. Trabectedin is approved for treating patients with unresectable or metastatic liposarcoma or leiomyosarcoma who have previously received an anthracycline-containing regimen. It's given as a 24-hour IV infusion every 3 weeks, usually with dexamethasone pre-medication to reduce liver toxicity. Its main toxicities are transient liver enzyme elevations, usually managed with steroids, fatigue, and mild myelosuppression. Rhabdomyolysis is a rare but serious risk. Lurbinectedin is a structurally similar analog, also binding the DNA minor groove and causing G2M arrest. It received accelerated FDA approval in 2020 for treating metastatic small cell lung cancer that has progressed after platinum-based chemotherapy.
Hijacking the repair system, that's ingenious. Now let's transition to the final category in our deep dive. Drugs of diverse mechanisms of action. These agents don't fit neatly into the previous classifications, but are still crucial players in cancer therapy. We'll start with bleomycin.
Bleomycin is another unique anti-cancer antibiotic, actually a mixture of related glycopeptides isolated from Streptomyces verticillus. Its importance lies in its unique mechanism and, crucially, its distinct toxicity profile, which often doesn't overlap significantly with other cytotoxic drugs, making it valuable in combination regimens. It plays a key role in curative therapy for Hodgkin disease and testicular cancer. Its cytotoxicity results from oxidative damage to DNA. The bleomycin molecule binds to DNA and also chelates metal ions, particularly iron, Fe2+. In the presence of oxygen, this bleomycin Fe2+ complex becomes activated and transfers electrons to molecular oxygen, generating highly reactive oxygen radicals, superoxide and hydroxyl radicals. These radicals then attack the DNA backbone, causing both single and double-stranded breaks, leading to fragmentation of the DNA and release of free bases. This damage causes cells to accumulate in the G2 phase of the cell cycle and leads to chromosomal aberrations. An important aspect is its degradation. Bleomycin is inactivated by a specific enzyme, bleomycin hydrolase. The levels of this enzyme are notably low in the skin and lungs, which may explain why these organs are particularly susceptible to bleomycin toxicity. Resistance can occur through increased hydrolase activity, decreased drug uptake, enhanced DNA repair, or drug inactivation by cellular thiols.
So, radical damage to DNA. What are its key uses and, importantly, its unique toxicities, given that it spares the bone marrow?
Bleomycin is given FARV, IM, or SC. Because it's cleared by the kidneys, doses need reduction in renal impairment. It's highly effective against germ cell tumors of the testes and ovary, forming the backbone of curative regimens for testicular cancer, like BEP, bleomycin, etoposide, cisplatin. It's also a key component of the ABVD regimen for Hodgkin disease. It can also be instilled directly into the pleural cavity to treat malignant effusions. Its major advantage, as you noted, is that it causes very little myelosuppression, which is a huge benefit when combining it with marrow-toxic drugs. However, it has significant cutaneous toxicities, including hyperpigmentation, hyperkeratosis, thickening of skin, erythema, ulceration, and sometimes Raynaud's phenomenon, or a peculiar flagellate dermatitis, itchy linear streaks. But by far the most serious adverse effect is pulmonary toxicity. This typically presents as pneumonitis with dry cough, shortness of breath, and infiltrates on chest X-ray, which can progress to potentially irreversible and life-threatening pulmonary fibrosis. The risk is related to the total cumulative dose. Risk increases significantly above 250-300 units, older age, renal impairment, underlying lung disease, and possibly exposure to high oxygen concentrations, EDM during surgery. There's no specific treatment other than stopping the drug and supportive care. Steroids may help in the early inflammatory stages. Another peculiar reaction, mainly in lymphoma patients, is an acute fulminant reaction with high fever and hypotension shortly after infusion, possibly due to pyrogen release.
That lung toxicity is definitely the major watch-out for bleomycin. Next up, mitomycin.
Mitomycin, or mitomycin C, is another antibiotic derivative with alkylating activity. Its clinical utility is somewhat limited today, often replaced by more effective or less toxic drugs, with a notable exception being its use in combination with 5-FU and radiation for treating anal cancers, where it can be potentially curative. It's also used by direct instillation into the bladder for superficial bladder cancer. After intracellular activation, enzymatic reduction, mitomycin becomes a bifunctional or trifunctional alkylating agent. It inhibits DNA synthesis and creates interstrand crosslinks in DNA, primarily between guanine residues. These crosslinks block DNA replication and lead to strand breaks. It's also a potent radiosensitizer. Resistance can involve deficient activation or drug efflux. Its major dose-limiting toxicity is myelosuppression, which is often delayed and cumulative, meaning recovery can take 6 to 8 weeks after a dose. A serious, though rare, complication seen particularly at higher cumulative doses is a hemolytic uremic syndrome, HUS-like condition, involving microangiopathic hemolytic anemia, thrombocytopenia, and progressive renal failure, which is often fatal. Interstitial pulmonary fibrosis can also occur.
Okay, let's discuss mitotane, that unusual compound chemically similar to insecticides. What's its unique niche?
Mitotane, OPDDD, is structurally related to the insecticide DDT. Its sole clinical use is in the treatment of adrenal cortex carcinoma. Its mechanism isn't fully elucidated, but causes relatively selective destruction or atrophy of adrenocortical cells, both normal and neoplastic, while generally sparing other organs. This leads to a rapid reduction in the production of adrenocorticosteroids and their metabolites, which is useful both therapeutically, for controlling Cushing's syndrome associated with functional tumors, and for monitoring treatment response. Because it damages the normal adrenal cortex as well, patients receiving mitotane require replacement therapy with glucocorticoids and sometimes mineralocorticoids to prevent adrenal insufficiency. It's given orally, often for prolonged periods. Adverse effects are common, primarily anorexia, nausea, vomiting, somnolence, and lethargy.
A very specific target. Now, for L-asparaginase, this one sounds like it exploits a very particular metabolic vulnerability in leukemia cells.
Yes. L-asparaginase, LASP, is an enzyme, not a conventional cytotoxic drug. Its use is primarily in treating acute lymphoblastic leukemia, ALL, especially in children, where it's a standard component of combination therapy. Its ingenious mechanism exploits a metabolic quirk. Many malignant lymphoid cells, like all blasts, lack sufficient activity of the enzyme asparagine synthetase, which means they cannot produce their own supply of the amino acid L-asparagine. They become dependent on obtaining asparagine from the bloodstream. L-asparaginase catalyzes the hydrolysis of circulating asparagine into aspartic acid and ammonia. By depleting the extracellular pool of asparagine, the drug effectively starves the leukemic cells of this essential amino acid, leading to an inhibition of protein synthesis and ultimately cell death. Normal cells having sufficient asparagine synthetase are much less affected. Resistance usually arises through the induction of asparagine synthetase activity in the tumor cells.
Starving the cancer cells clever. How is it administered, and what are the main challenges with using an enzyme therapeutically?
L-asparaginase is typically derived from bacteria, E. coli or Erwinia chrysanthemum. Because it's a foreign protein, a major challenge is hypersensitivity reactions, ranging from urticaria to life-threatening anaphylaxis, which occur in a significant percentage of patients, especially with intermittent dosing. To overcome this and prolong its duration of action, a modified form called pegaspargase, pegylated asparaginase, was developed. Attaching polyethylene glycol, PEG chains, reduces the enzyme's immunogenicity and dramatically slows its clearance, allowing for less frequent administration, for example, every 2 weeks instead of every few days, and often enabling treatment even in patients who had allergic reactions to the native enzyme. Pegaspargase is now standard in frontline all therapy. Even with pegaspargase, silent inactivation by neutralizing antibodies can occur, potentially reducing efficacy without obvious allergic symptoms. Other toxicities of asparaginase relate primarily to its inhibition of protein synthesis in normal tissues, particularly the liver. This can lead to hyperglycemia due to decreased insulin production, clotting abnormalities due to deficient synthesis of clotting factors, leading to risks of both thrombosis and hemorrhage, hypertriglyceridemia, and hypoalbuminemia. Pancreatitis is another serious potential complication. Neurological effects like confusion or coma can also occur.
Hypersensitivity and effects on protein synthesis sound key. Let's discuss hydroxyurea, HU. It seems to have a remarkably diverse set of uses, from cancer to sickle cell disease.
Hydroxyurea, HU, is indeed fascinating for its multiple roles. Its primary anti-cancer mechanism is the inhibition of ribonucleotide reductase, RNR. RNR is the enzyme responsible for converting ribonucleotides, the building blocks of RNA, into deoxyribonucleotides, the building blocks of DNA. This conversion is a rate-limiting step in DNA biosynthesis. HU specifically inhibits RNR by scavenging a critical tyrosyl free radical required for the enzyme's activity. By inhibiting RNR, HU depletes the intracellular pool of deoxyribonucleotides, thus inhibiting DNA synthesis and repair. This makes it S-phase specific, and it causes cells to arrest at or near the G1S boundary. This cell cycle arrest at the G1S interface also makes cells highly sensitive to the effects of ionizing radiation, so HU is often used as a radiosensitizer in the treatment of cancers like cervical carcinoma or head and neck cancer, given concurrently with radiation therapy. Its depletion of deoxynucleotides can also potentiate the effects of other DNA-damaging agents or facilitate the incorporation of other antimetabolites like Ara-C or gemcitabine into DNA. In myeloproliferative syndromes like chronic myeloid leukemia, CML, though largely replaced by TKIs, polycythemia vera, and essential thrombocythemia, HU acts as a myelosuppressive agent to control elevated blood cell counts, white cells, platelets. And perhaps most remarkably, HU is the primary drug used to treat sickle cell disease. It significantly reduces the frequency of painful vaso-occlusive crises, hospitalizations, and the need for blood transfusions. Its mechanism in sickle cell is complex and not fully understood, but involves several factors, including the induction of fetal hemoglobin, HbF production. HbF inhibits the sickling of red blood cells, reduction of neutrophil counts, which contribute to vaso-occlusion, and possibly effects on nitric oxide production and cell adhesion.
That HbF induction is amazing. What are the main toxicities of HU? Does it carry that secondary leukemia risk?
The major dose-limiting toxicity of HU is myelosuppression, leukopenia, anemia, sometimes thrombocytopenia. But this is generally rapidly reversible upon stopping the drug. Mild GI disturbances and dermatological reactions can occur. Painful leg ulcers can be a problem, especially in elderly patients. Importantly, unlike many other cytotoxic agents used for myeloproliferative disorders, long-term use of HU for conditions like essential thrombocythemia or sickle cell disease does not appear to significantly increase the risk of secondary leukemia.
Right.
This is a major advantage. However, it is considered a potent teratogen in animals, so its use should be avoided in pregnancy or women of childbearing potential without effective contraception.
Good to know about the leukemia risk profile. Next, let's talk about retinoids, specifically tretinoin or ATRA. I understand this drug represents a different therapeutic paradigm, inducing differentiation rather than just killing cells.
That's exactly right. Retinoids, particularly tretinoin, ATRA, which is all-trans-retinoic acid, a derivative of vitamin A, are the prime example of differentiation therapy in cancer. The idea is to overcome the block in maturation that is often a hallmark of malignant transformation, forcing the cancer cells to differentiate into mature, non-proliferating cells which then die naturally. ATRA has had a revolutionary impact on the treatment of one specific type of leukemia, acute promyelocytic leukemia, APL. APL is characterized in over 95% of cases by a specific chromosomal translocation, T1517, which creates a fusion gene between the PML gene and the retinoic acid receptor alpha, RRA gene. This PML-Aroa fusion protein acts as an aberrant transcriptional repressor, blocking the normal differentiation of myeloid precursor cells at the promyelocyte stage. Pharmacological concentrations of ATRA are able to bind to the abnormal RRI part of the fusion protein, overcoming its repressive effect, releasing the block on transcription, and inducing the leukemic chromolycytes to differentiate into mature neutrophils. ATRA also promotes the degradation of the PML-Aroa fusion protein itself. As a single agent, ATRA induces complete remission in a very high percentage of APL patients, rapidly reversing the dangerous coagulopathy often associated with this disease. When combined with the anthracycline-based chemotherapy, and now often with arsenic trioxide, it leads to long-term cure in the vast majority, 80–90% plus, of APL patients. It truly transformed the outcome for this leukemia subtype. Resistance can occur through mutations in the fusion protein or induction of enzymes that degrade ATRA.
That's a remarkable success story for targeted differentiation therapy. What about its most distinctive adverse effect, that differentiation syndrome?
Yes, the most significant and unique toxicity associated with ATRA therapy, and also seen with arsenic trioxide and APL, is the retinoic acid differentiation syndrome, also just called differentiation syndrome. This typically occurs during the first few weeks of treatment, especially in patients starting with high white blood cell counts. It's thought to result from the rapid differentiation and release of cytokines by the maturing leukemic cells. These differentiating cells express high levels of adhesion molecules, causing them to aggregate and infiltrate tissues, particularly the lungs. Symptoms include fever, respiratory distress, dyspnea, weight gain, pulmonary infiltrates on X-ray, pleural or pericardial effusions, and hypotension. It can be life-threatening if not recognized and treated promptly. The standard management involves immediately starting high-dose corticosteroids, like dexamethasone, and sometimes temporarily holding the ATRA or adding cytotoxic chemotherapy, like hydroxyurea, to reduce the white count. With prompt treatment, the syndrome is usually reversible. Other common side effects of ATRA are typical of hypervitaminosis, dry skin, cheilitis, cracked lips, headache, sometimes pseudotumor cerebri, bone tenderness, and elevated liver enzymes or triglycerides.
Finally, let's wrap up our deep dive with arsenic trioxide, ATO, which you mentioned also plays a key role in APL. How does arsenic, traditionally known as a poison, work as an anti-cancer agent?
Arsenic trioxide, ATO, ACE203, is another agent that has shown remarkable efficacy in APL, particularly for patients who relapse after or are resistant to ATRA and chemotherapy. It induces complete responses in over 85% of relapsed APL patients. Its exact mechanism of action in APL is complex and still under investigation, but it appears to have dual effects. At low concentrations, similar to ATR, it seems to induce partial differentiation of APL cells. At higher concentrations, it directly promotes apoptosis. One proposed mechanism involves the generation of reactive oxygen species, ROS. ATO can inhibit enzymes like thioredoxin reductase, leading to increased intracellular ROS. APL cells seem particularly sensitive to this oxidative stress. ATO also promotes the degradation of the PML-Aroa fusion protein, similar to ATRA, but through a different pathway involving summylation and proteasomal degradation. It can also modulate various signaling pathways involved in apoptosis, like activating caspases and downregulating BCL2. Interestingly, recent studies suggest ATO might even bind to certain mutated forms of the p53 tumor suppressor protein and restore some of its normal function in other cancer types.
Dual action differentiation and apoptosis. What are the main side effects to watch for with arsenic trioxide? Is it as toxic as its historical reputation suggests?
At the pharmacological doses used for APL treatment, ATO is generally surprisingly well tolerated, much better than its reputation as a poison would suggest. Common side effects are often mild and reversible, including fatigue, nausea, diarrhea, abdominal pain, lightheadedness, transient liver enzyme elevations, and mild hyperglycemia. The differentiation syndrome, similar to that seen with ATRA, can occur in a minority of patients, 10%, and requires the same management with corticosteroids. The most significant potential toxicity is cardiac. ATO is known to cause QT interval prolongation on the electrocardiogram in a substantial proportion of patients, around 40%. While usually asymptomatic, significant QT prolongation increases the risk of developing a potentially fatal ventricular arrhythmia called torsade de pointe. Therefore, careful monitoring of the ECG and serum electrolytes, particularly potassium and magnesium, which must be kept in the normal range, is essential during ATO therapy. Drugs known to also prolong the QT interval should be avoided concurrently. Treatment is usually held if the corrected QT interval exceeds a certain threshold, for example 470 milliseconds, and resumed only after it returns to normal.
Wow. That was truly an intensive deep dive. From World War I, chemicals repurposed for healing, to complex molecules from plants, bacteria, and even sea squirts. The journey of discovering and refining these cytotoxic and antimetabolite drugs is nothing short of incredible. We've seen how they relentlessly target cancer cells by disrupting their most fundamental processes, DNA replication, repair, cell division, really showcasing a drive towards mastery in this chemical warfare against disease.
Absolutely. And what this comprehensive exploration really reveals is the exquisite precision required in this field to achieve that mastery. Understanding not just what these drugs do, but how they're metabolized, how resistance emerges, their specific, often unique adverse effects. Grasping all that is absolutely crucial for optimizing patient outcomes and minimizing harm. The interplay between cellular biology, chemistry, and clinical practice is just on full display here.
It's clearly a field of constant evolution, isn't it? Driven by an ever deeper understanding of those intricate cellular pathways and a relentless pursuit of better, more targeted treatments. So, what does this all mean for you, our curious learner aiming for that professional level grasp? It means you now possess a foundational understanding that goes far beyond the headlines, hopefully.
Yeah.
A true sense of mastery over the sophisticated chemical arsenal used in the ongoing fight against cancer.
Indeed. And perhaps the biggest aha moment, thinking back over everything we've covered, is recognizing that delicate balance with every single drug. A balance between efficacy and toxicity, between exploiting cancer's weaknesses and preserving normal tissue function. This really raises a critical question for the future, doesn't it? As our understanding of cancer at the molecular level continues to explode, genomics, proteomics, epigenetics, how will these traditional cytotoxic and antimetabolite approaches integrate with, or perhaps even be transformed by, the era of precision medicine and targeted therapies?
That's a fascinating thought to ponder. How do these powerful broadswords of chemotherapy fit alongside the scalpels of targeted therapy? It highlights the ongoing dance between discovery and application in medicine. We truly hope this deep dive has given you a profound appreciation for the science, the history, and the immense dedication behind these often life-saving, though challenging therapies. Until our next deep dive, keep learning, keep questioning, and stay well informed.